things. So one of the things I wanted to do, we're in our third year of doing stem cells and 25th year of regenerative medicine and integrative medicine. And I wanted to give an update because there's a lot of things that are new. I'm going to take this opportunity to kind of go into some of the new approaches, but also to review what a good functional medicine chronic condition approach would do. For some people, we're going to go through the basics because, you know, you can never do too many basics on this kind of thing. And I want to review some of the questions that we're getting on an ongoing basis. So Advanced Regen Medical is really a compendium of different kinds of doctors. So we have an MD who is a triple board certified internal medicine doctor. We've got an osteopath who sort of philosophically is more like me. I'm the clinic director, Dr. Santucci. So my first license was a chiropractor, but I don't actually do very much chiropractic, hardly any at all. So I'm really a functional medicine doctor, and I have 1,000 hours postdoctorate neurology. So one of the things that we think that you have to do if you're going to do good medicine is you've got to get the diagnosis right. So we bring all of those people in. We're on our third year of stem cells. So just like you, we're students. So we looked at what was available. We looked at what people were saying. Some of the things people are saying about stem cells just didn't turn out to pan out right, and I'm going to go into some of that. Some of the things about stem cells are way better than what people are saying. So we have personal experience, we've got tons of clinical experience, we're measuring everything. We're heavy technology. If there's a gadget that does something better, we try to own it. One of the things that I think is kind of a deficit in normal medicine is everybody's just practicing their little niche. So I'm personally in favor of the informed generalist who can come in with an armamentarium of things that kind of address your problem. So when we look at that, we're going to take things from the medical side, from you know, the more integrative side, and from the holistic side, and kind of match them all to a single solution. So one of the things that I want to really make plain here is that integrative medicine is new. So if you were an orthopedist and you're used to doing knee surgeries and shoulders, you could change and adopt this as part of your technology. In fact, a lot of orthopedic surgeries are being done with stem cell washes where they basically do the surgery and then bathe the area in stem cells, and the outcomes are significantly improved. You could be an acupuncturist. I was sort of jealous of the acupuncturists because basically they're really good with needles. So we come in with an ultrasound and we're super careful about not touching anything we shouldn't touch. The acupuncturists come in and, you know, the front part of the shin, they're doing a tibialis anterior tendon insertion, and they're peppering the bone, because their comfort level with sticking needles in people is so high. So I actually think the acupuncturists are one of the groups that's just really good at this. I also know that there's some MDs that are really good at this. So a friend of mine who is an anesthesiologist is doing hydroablation. It's art. It's just so good. So different kinds of doctors, nurse practitioners, even dentists, some MDs, certainly some chiropractors, certainly some osteopaths, certainly some functional medicine kinds of people are in this world. There's 800 clinics at this point, so it's not some fly-by-night thing. There's 800 clinics and there's over 100,000, and 100,000 not just successful transplants, but 100,000 transplants with no adverse medical events. So I think that probably puts this in the safest procedure that's ever existed. Literally getting your teeth cleaned at the dentist is more dangerous than getting stem cells. So one of the things that we face a lot is people with just abject disbelief, like this can't work. And one of the issues about stem cells, and I'll go into it when I talk about the characteristics of stem cells, is stem cells repair your body the exact way you're repairing your body right now. So you don't have to know how it works. It's a little bit like your car. You don't really know how it works most of the time, but it still works. Well, most of the time when you're doing cellular healing, let's suppose you scrape the skin off your hand with a razor blade, your body would generate cytokines and inflammatory mediators, which would attract the stem cells, blood-borne stem cells. They would go to that site and they would repair the skin. It's not under your conscious control. And frankly, you don't know how that works because almost nobody does. The DNA of the stem cell would transform from a blood-borne DNA to a dermal DNA. You don't end up with blood on your hand, you end up with new skin. So there's actually a DNA to RNA transcription process that's pretty elegant. And so stem cells are kind of a miracle. They're kind of a natural miracle. So we do think that we need to look more and more into the actual working of them and making sure that we understand the process as much as we can. But I don't think that there's 10 people in the world who actually understand how cellular healing really works at the DNA level. Having said that, we can measure outcomes, and the FDA measures outcomes. So there's something called a 501c report, which is an adverse medical event, and you can look that up online. There's never been a 501c on a umbilical cord stem cell, the highest quality stem cells. What's happened now at 3 years, knees, shoulders, systemic arthritis are pretty common conditions. We do a lot of them. Everyone does a lot of them. Everybody has very good results. There's some new technology. We're doing intranasal stem cells for dementia, Alzheimer's, those kind of things. You can actually place stem cells within the cerebral spinal fluid of the brain. So all of a sudden we can address brain inflammation, and that can make a huge difference. I had it done. It helped with my short-term memory. My wife had it done. It helped with hers. It's kind of a big deal in terms of, where we're going with this in the future. I'd say the big horizon in the future is going to be wound care. Aesthetics is already kind of taking off. The aesthetics people are early adopters. So people are using it for hair loss. They're doing microneedling on face. There's some scar tissue rejuvenation that's showing lots and lots of good results. In all of the provisional activities, you can't say that it's FDA approved, and you can't say that there's definitive science. Because remember, a lot of that is a rigged system. The placebo-controlled double-blind study is never going to be done on stem cells. First of all, you don't have any advocates. And remember, the advocates of medical research are generally drug companies. So stem cells are probably the farthest thing from a drug company solution as you can possibly get. It's a natural thing. And what's happening is the clinical outcomes are establishing not just the safety, but the efficacy. So when people say, oh, it just doesn't work, I'm always like interested in that. I'm like, okay, I totally am interested in having the other side of that argument. Because what we're seeing is that it works on almost everybody. There's a perception in some people that it didn't quite solve every problem that they ever had, and so they're like labeling it as a failure. But the reality is 80% of the people are getting about a 50% increase in strength and range of motion, which are really significant orthopedic results. So one of the things about stem cells is there's kind of a tendency of medicine in general to drag their feet on new stuff. So when we look at FDA approved, completely accepted rehab technologies, we notice nobody has them. So all the latest stuff in the last 10 years, if you go to your physical therapist, if you go to your occupational therapist, if you go to your big box store rehab center, they're using balls and bands and maybe weights. Nobody's using the new neurologic or vestibular rehab equipment because it costs too much money and it requires extra training. So in areas of orthopedics where we know that there's better stuff, we don't see people using it. Stem cells are going to be almost an exaggeration of that because stem cells now mean that the doctor needs to change what he does and probably needs to take a more holistic approach and really take some more responsibility. I'm going to go into that. One of the things that we're looking at is what's the right combination. Probably the hardest thing to determine as a clinic designer, as a clinic manager, is what do you offer? So we just stopped doing neurofeedback, and brain scans. We like that technology. The delta theta alpha beta wave stuff is amazing, but we're really going to concentrate on, the holistic functional medicine, complete answer, regenerative medicine, nerve rebuilding, tissue rebuilding area. One, because nobody's really doing it in a comprehensive way, and two, because there's going to be a revolution in this, partially because Medicare is now sanctioning some of the basic level procedures, and I'm going to go into that. So how do stem cells work? And this always kind of amazes me. A single stem cell, the ones we're using are called omnipotent cells. They can become 122 different kinds of cells. For our purposes, we want them to become cartilage, we want them to become nerves, we want them to become blood, we want them to become muscle cells, liver cells. Your body can be prompted to create stem cells. Significant levels of exercise can do it. There's some people who think that you can do it nutritionally. I'm not a big advocate of that. I don't think it works very well. Restoring cellular reserves nutritionally is always a good idea. It's one of the key things. Reduce inflammation, restore cellular reserves. It's a standard functional medicine answer to things. But from a stem cell actually working point of view, what stem cells need is a supply of stem cells. And so there's 4 or 5 ways that you can get extra stem cells. But stem cells are attributed with basically the renewal of tissues. So stem cells can go into a tissue that's creating an inflammatory response and repair it and replace it. So remember, stem cells can regenerate tissue. Angiogenesis means that they're regenerating blood vessels. Cytokines are chemical messengers that help with repair. Immunomodulatory effects. This is kind of a subtle point, but it's huge. So just like vitamin D balances the Th1, Th2 systems, so does stem cells. In one of my talks, I showed all the research that was on that, but that's a huge point. Matter of fact, this whole slide is pretty significant. Because now, you still have to look at the autoimmune triggers. I wrote a book on it, and we've presented a couple of presentations on balancing autoimmune triggers. So, we're looking at food, we're looking at metals, we're looking at hormones, we're looking at stress, we're looking at trauma. But basically, those autoimmune triggers are probably responsible for anywhere from 1/3 to half of these idiopathic diseases. So lots of people that come to our clinic for stem cells have these systemic arthritides or multiple autoimmune complexes, and they really need to be looking at the immune part. The stem cells will draw a line in the sand and make you better at dealing with that. It'll work a lot better if you stop the primary antigen, which means probably changing your diet, which means probably figuring out when you got the metal toxicity, which means going after those female hormones or male hormones. The next one is controversial because chemotherapy is such a big deal in this country, but basically anti-apoptotic means that it's anti-cancer. So there's a lot of confusion when it comes to cancer and stem cells because the radiologist basically, the oncologist, radiologist are irradiating immune systems, basically killing all the B cells of the immune system and then transplanting stem cells. So they have to be very careful with host versus graft and a whole bunch of things that does not apply when we're doing umbilical cord transplants in otherwise healthy people. But the research is saying that there's significant anti-cancer activity with stem cells. And I'll leave it at that. But again, if I got cancer, I would do 2 cc's of IV stem cells in about 5 minutes and begin to do things. Paracrine effect is, again, a chemical modulator. So the microchemistry of stem cells is that it sets you up to heal. And then it activates your own stem cells. So in an umbilical cord sample, there's stem cells, there's exosomes, which are chemical mediators that tell your system to generate your own stem cells. And then there's a host of other chemicals, which again activate regeneration. So in general, when you're doing this amount of activity, you're going to address the underlying, or at least the medium level causation of most chronic conditions. So we are doing a webinar, and in order to do that, we put a message out to our constant contact list. So it's a couple thousand people, and about 500 of them actually open up their emails, so it's not that many. And then we put ads out in on Facebook, because that seems to be the way to communicate. So I was kind of like, okay, we can't really do face-to-face workshops, so we should advertise on Facebook. So we do that. And you kind of can't believe the blowback. And I know the people that do this say just ignore the crazy people, but I wanted to kind of address the crazy people, because what we're getting is it's either we're preaching to the choir and people are sending us little pictures of hearts and angels and saying it's all so great, or we're getting these people who are just like, it's not real. And I was like, there's been 100,000 successful injections. It's real. There's 600 clinics. It's real. There's major FDA approved labs, the best, United States, in my opinion, has the best labs in the world now. That's already happened. People are spending millions of dollars on this technology. California even, wanted to do their own research on it. And so we're so far from it doesn't work, it's not real. And so again, in our clinic, we try to objectify everything, because it's hard to understand what's going on in general with patient outcomes, because the patient has a subjective viewpoint. We're measuring certain things. Assessment tests can tell us other things. Lab tests and physical exams can tell us other things. But when we look at that, we're seeing about a 50% improvement in physical symptoms of people that get stem cells. Do we have people who think that nothing happened? Yes. I literally had a person the other day. We had 100% improvement in strength and range of motion, and she still has a little bit of pain in her legs, so she doesn't think anything happened at all. Well, that's a patient perception thing, and you're never going to get that perfect. But again, when we're looking at people who are kind of being objective about it, it's a landslide, it's an avalanche. And the other thing is, it's much better than the alternatives. So when we look at orthopedic outcomes, it's about 50-50 on patient perception about whether the thing actually, was better than not getting it. A big advantage of regenerative solutions is there's almost no recovery time. So if you get a stem cell injection, you don't have to change very much. So when we went through this, this was the initial analysis that we used to kind of pick which kind of stem cells we did. And in those days, 3 years ago, there was a big controversy on, do you use fat or bone marrow, or even plasma-rich protein, stuff from the patient themselves. So the initial concerns were that, there's no host versus graft, you don't have foreign things in you, and it's all much safer. Well, it turned out it wasn't much safer. It was much less safe. So within an envelope of all these procedures are way safer than surgery. They still are not as safe as an umbilical cord or an amniotic, really, transplant. So because there's processing, there's two different procedures where you're harvesting the bone marrow or the fat, they ended up not being as safe. There's discomfort and infection, especially in the bone marrow and fat part of it. PRP, not so bad. And PRP, honestly, I'm looking at it again, because we're always looking at everything. This isn't a religion. We're not tied to any one outcome. It's what's the reasonable thing to do. PRP has a matrix in it. So plasma-rich protein, your own blood spun down and re-injected. I'm thinking of doing it on my ankle, because the talocrural joint in my ankle doesn't have enough space after my 7th knee operation, and it kind of messed up the mechanics of it. So a very, very, very smart doctor was helping us with that. And he basically was like, no, PRP is the preferred tissue for you. So we're getting a centrifuge, and we're going to spin down my blood, which has a lot of stem cells in it, because I've done a lot of stem cells. And we're going to see how that actually works. We're going to see, what that outcome actually is. If it works on me, my assumption is it'll work on other people, and, it's a safe procedure. So we're still talking about 1% adverse medical events though, and we're coming from a world that has none. So we're going to do that cautiously, but we're definitely looking at it. When we're looking at our preferred media, we're using umbilical cord blood with added exosomes because the research all says that that has the most colony forming units and the least problems. The world is changing. So one of the things that's happened in year 3 is that the FDA has provisionally approved and Medicare is provisionally approving some amniotic, filtered amniotic products. So we're looking at that as an option, mostly because of cost. We don't think that they are competitive in terms of their performance, but we think it's a beginning. And frankly, this is a little bit like the Berlin Wall coming down. We're interested in things that are allowing stem cells to go to the general population. We probably have 1,000 people who couldn't afford stem cells. And in those days, we couldn't get the medical financing groups to really do anything reasonable. And it just was out of touch for a bunch of people. So we think that the filtered amniotic product is actually a decent beginning and really a hallmark of this getting bigger government and Medicare acceptance. So this is what it's really boiling down to. So in our clinic, we're using mostly umbilical cord stem cells because we can do an IV, which will address arthritis, lungs condition like COPD, and cognition, brain function. This for us is kind of the holy grail. These are very, very difficult things to fix, and we're getting incredible results on them. We've taken some very, very difficult patients and gotten, pretty decent outcomes on this. The amniotic-derived stem cells, they're actually not stem cells. It's amniotic fluid that they filtered out the stem cells. They're good for joint injections only. They can't be used as an IV, so they can't do for systemic stuff. They have provisional FDA approval, and they're covered by Medicare. So if you're 65 and you have a joint problem, that might be something we look at. Exosomes is the other thing that we were doing more of. Frankly, we may substitute PRP for exosomes. Exosomes, again, like the amniotic-derived products, don't have any live cells. So it means that it's basically using chemical modulators. So when we look at exosomes, sort of go into here, there are definitely providers that prefer exosomes to all other regenerative mediums. And having done almost all of these things myself, and sometimes a couple of times, I personally don't think exosomes are anywhere near as good as stem cells. But to be fair, we're putting it out there. So somebody came in and they said, I absolutely just want exosomes. I don't want any live cells. I don't want to deal with host versus graft. I don't want to deal with the concept at all. We would do that, at least for a little while more. I'm now trying to look at it from an efficacy point of view because, again, the safety's there. I'm just not sure they work that well. So from my point of view, I don't want them. But again, we have patients who have done their research, they feel strongly about it, and it's something that we can do. Flower Amnioflo is an initial example of an FDA-sanctioned procedure with a CPT code, which means that it's Medicare billable. So Flower is an orthopedic supply company that figured out a way to get a billing code for this. So it's actually billed as an orthopedic device. It's interesting. So it's a filtered product. There's no stem cells in it, but it does enhance the body's chemical capability to produce stem cells and to initiate healing. It's definitely better than collagen. It's definitely better than anabolic steroid shots because it doesn't destroy the tissue that it's being put in. It's provisionally FDA and Medicare approved only for joint injections. And I'll tell you, this created a significant amount of change and work in our clinic. So one of the things that we did in the COVID world is that we got a new patient EHR, electronic health record system, and we've spent about 3 months implementing it. So it's a lot of work. So we have 2 new technologies that Medicare will pay for. One of them is Synexus, which is a nerve rebuilding for peripheral neuropathy, works really well. So if you're 65 and you have peripheral neuropathy, you should come and talk to us. The other thing is if we have a joint problem, then we can do this first level and actually have that be Medicare reimbursable. This is a big deal. Let's face it, insurance companies are dictating what's affordable. With regular stem cells, with the umbilical cord stem cells, patients are putting out between $6,000 and $10,000 of their own money. The least is like $3,500. But it's a financial burden for lots and lots of people. When I was doing my own, I had to borrow the money when I was really, really sick to do the stem cells. It wasn't an easy thing for me to put out $3,500 4 times. But I did it, and it was part of the reason that I had the significant recovery that I did. So I'm a real believer. I think if we can make the Medicare billable part work and make the part that's patient pay work as another step, I think we've got a good graduated offering. So when we're looking at umbilical cords, they're kind of the rock star. So we can use them for knee injections. We can do them intranasal and get to the brain. Most of the time, their big benefit is in systemic arthritis and bronchial problems. So because a stem cell in a vein is deoxygenated blood, so, it's blue blood. So it has to get oxygen, which means it's going to go to the right atrium, the right ventricle, go to your lungs. So the stem cells actually get delivered to the pleural tissue, to the lungs. So we've seen pretty significant cases of COPD be resolved with stem cells. We're measuring, so we're doing tidal volume with respirometers, and on that, we're getting about a 40% change on a couple of our patients. We've done a couple of autoimmune, almost cystic fibrosis of lungs patients that didn't respond at all. So it's not, a guaranteed thing. It's not the Holy Grail, but it's a very positive thing. And we think decreasing the systemic arthritis in these autoimmune cases is a huge deal. So the other thing that can be said here, and it's more of a hopeful statement in terms of the FDA really is conflicted in terms of their handling of stem cells. On the one hand, there's big prohibitions to say, don't trust anybody that's making any medical claims, and there's no science at all. On the other hand, they're sanctioning the labs, and they're basically saying this is the medicine of the future. So long story short, I think that we're in a transition time. I think that these are big, institutions, and it takes a little while to get the change. I'm happy that there's Medicare billing regenerative products. They're not stem cells, but they're umbilical cord fluid, and they have a lot of the right properties. I think that we're in a position that, that's going to begin to change. I think that there's a general environment of openness and kind of awareness that there's something here. So we're hoping to be a big part of that. So what does an injection actually look like? Whoops, let's go back here. So, so we use ultrasound guidance for most of our injections. So if we're going into I'm trying to get this guy to start. We're using ultrasound guidance. It's pretty simple. You're on a table, that's an ultrasound. We're envisioning exactly where we're going. This is an AC shoulder adjustment. This guy was a pitcher as a young man and completely separated the AC joint. We have about 110 degree range of motion that's now turned into about 150 degrees. That's a huge difference. And so we've done significant rehab using sound waves on the shoulder, but also the stem cells are 90% really responsible for making a change in somebody, over 70 years old. If we're using the Medicare billed products, we can only do 1 injection per visit. So we usually do them, a week interval. There's minimal recovery time. Well, we don't want you to go out and start Irish dancing, but in general, most patients can just resume their normal activity. It's not like a medial meniscectomy or a discectomy laminectomy, or any of the surgical processes that can take years to get better, and again, the world has kind of whitewashed how serious surgeries are. Surgeries are still a major reason that we have adverse medical events and even death. And then recovery times are taking a lot longer than people are giving as estimates. We're hearing 2 weeks and it's taking 2 months or 2 years. And, in one of my knee surgeries, it took me 3 years to actually restore how I was the day before the operation. So one of the things that I'm looking at as I get older, I'm actually thinking of changing what I do. And I have strong feelings at this point about the medical standard of practice. So I look at each one of the healthcare providers and go, the current specialist system that we do kind of sets you up with somebody who can give you the answers, but isn't responsible for your case. So the informed generalist, general practitioner model is kind of the one that I'm advocating. So I'm basically saying that first person that you go to, what if he did everything we know how to do? And so maybe had you in with a specialist, but maintain control. And one of the things that we see with our most successful patients is they've prioritized their health status. They care how they're doing. At the same time, we've got a whole bunch of people that would rather die than pay more than their copay. And I am suggesting that people change their prioritization here. We live in a community where $100,000 cars are normal, but if you tell someone to spend $10,000 on really changing their health outcome, it's like a big deal. So I think we have a priority problem in the United States. The other thing that we do is we like passive solutions. Take a drug for this, do surgery for that, it's covered by insurance, I don't have to think, I'll be unconscious, and I'll just deal with the fallout. That's really a strange way of handling probably your most prized possession, which is your health. So when you're designing this, you don't throw the baby out with the bathwater. There are proven historical remedies. I really like some of the balance things, energy balancing in traditional Chinese medicine. I think chiropractic is amazing. Chiropractic is totally undersold because they basically lost the fight with the AMA. But chiropractors from an orthopedic, holistic orthopedics point of view are probably, the best there is. They definitely know more about joint rehab, and chiropractors that know neurology know way more about diagnostics. In any case, we're going to combine the medical disciplines. And then when I looked for myself, I had reflex sympathetic dystrophy in my leg. My leg turned black, it exsanguinated, there was no oxygen in it. Well, I found a remedy that was done in Japan, so something called Kiatsu, which is a computerized tourniquet, and then saw the stem cells that were being done in Sweden, and then combined it with some of the German high-tech rehabs equipment. And when I looked at that all together, the combined solution was way more powerful than anything anybody else would do. The other thing is, and where we're at this point, is that we would use biologics. So at this point, using amniotic fluid, using stem cells, using exosomes, using something that tells your own body to repair itself is just a smart thing to do. But it's a non-standard thing to do. So if we're dealing with somebody who is a super late adopter, and this can be a doctor, because lots of doctors are late adopters, they're conservative by definition. They have a vested interest in being conservative. But it's also some people, like some of the people that like comment, I'm sitting there going, are you against electricity and, anything but horse-drawn carriages? Because they're so backward. So one of the things that I'm actually totally open to is someone who really has an opinion that this, could help them, but is worried about those details. I'm happy to share our level of details because we think we kind of know what's real and what isn't real. The other thing is there's kind of an overview that medicine in general is backed by like rigorous science. 80% of the drugs that are given to people are on off-label usage. So the FDA approved it for one thing, but actually people are doing, they're using it for a completely different thing. we're seeing antipsychotics being used for low back pain. No one ever approved that. And people are writing those scripts all day long. So when we're doing 5 times as many surgeries as the Western developed countries, than like Germany, then I think that it's time to take a look at that. So I do think that we need to question medical procedures, this one and the others. But when you do them side to side, this ends up being a very, very viable thing to look at. So when we're constructing a clinical solution, probably again, one of the hardest things there's to do in the clinic is decide what services to offer and which ones not to offer when the world's changing so much. So from my point of view, it all starts here. We need an accurate, in-depth diagnosis. I actually teach a course to all kinds of doctors on advanced diagnostics. So adding in the neurology and the biochemistry and the functional medicine and really all the different parts that could have caused an autoimmune disease. We made a chart, it has to be 10 years ago at this point. We made a chart that I put in my book and basically said, okay, these are some of the reasons people might have these so-called idiopathic chronic acute diseases. So it really starts there. So it's not a 15-minute analysis and plug and play and, sit on the machine and we're going to take care of you. When we're doing a chronic condition investigation, it's really, where did this come from? And, some of those answers are disturbing. We had a patient that, he was in military, he was hypothetically in a base that didn't have radioactivity, and he had uranium poisoning and 2 active fractures. So he's a 90-year-old. People are saying he's just this cantankerous old man. And we're like, yeah, he has broken bones in his back. Well, he had been to everywhere. He's one of those people who had been to 11 different doctors. It wasn't that difficult to figure out what was wrong with him once we went system by system by system. In our world, we think using quality stem cells is a big part of the answer. We see people who are very, very talented using PRP or using fat or using bone marrow, and we just don't think it has the colony forming units. Some of them are some of the best technique doctors, because remember, this is kind of an art and a science. It matters who's putting the injection, and it matters what their technique is, it matters how smart they are, how dexterous they are, all that stuff matters. But if you're using stem cells that are 5 times more virulent, have 5 times more colony forming unit capability, it's going to work better. On the rehab world, I kind of am a person that's been aggregating technology. We started off with a $100,000 low back spinal decompression machine, mostly to fix me. I had chronic low back pain and lightning going up my legs and doing all these things. So I fixed me with this machine, and I said, okay, this machine fixes L5S1 radiculopathy, even though the science said it didn't. And then we probably fixed 500 more people. When we're looking at rehab equipment, these days, it's really about energy and resonance. So pulse electromagnetic fields can be tuned to like geomagnetic or airborne or just serious amounts of square wave energy that can go in and repair the mitochondria, replenish like cellular reserves of every cell in your body. Well, that's a great thing to do. Synexus is a new technology that can basically go in and repair the inside of a nerve. Now, if we do the autoimmune triggers, probably take the person off of gluten and dairy and kind of pay attention to how the person got there, it's going to work better. But Synexus all by itself has very, very, very good clinical results. Miracle Wave is percussion. So it's actually sound waves. We can fix the inside of a shoulder. When we're doing like a modified trigenics procedure, which is an advanced neural release on shoulders, we can get strength and range of motion in shoulders without surgery, without drugs, and actually without stem cells. If we do it in conjunction with the stem cells, in conjunction with getting away from the immune triggers, it's going to work better. There's almost no one, in my opinion, that is doing the diet thing right. They're either doing extreme prohibitions of different food types and just going way, way, way too far, or not understanding some of our basic foods, and especially in the gluten and dairy world, have been chemically altered. So most people need a little bit of change there. One of my sole, kind of goals for most patients is to get them to exercise again, even if it's just walking around the block. When we're doing this, it's all with the kind of idea that we're going to change the patient's ability to deal with their own life. They can get up out of a chair without holding on. They can walk around the block. They don't fall. Their not just vestibular sense, but their balance in all aspects of life is actually improved. So this is the goal. When we're looking at doing it, these are some of the technologies that I just referred to. I didn't talk about Spine Force. Spine Force is a platform that moves around. You push and pull with different sides, and it measures the hemispheric control of the body. So from a balance point of view, this thing is so far ahead of what most people are doing. And this has got to be 15-year-old technology. Pulse electromagnetics, again, generates this huge square wave that can restore mitochondria. This is the new Synexus machines that, these cost $50,000 a piece. We have 2 of them, and these restore the inside of nerves. This is the percussion or the sound wave therapy. Again, you can go in and rehab tissues at a much deeper level without pain. So it's easy for the practitioner. You're holding it like a pencil. And then basically, this allows us to penetrate, in this case, plantar fasciitis, but lots of times we're doing shoulders with it and different things that's enabling us to send signals to the body that everything's okay. So if we come in, do an injection into a shoulder, do the sound waves, come in and do a peripheral neuropathy treatment on the arms, and then do PMF, we're probably going to create kind of a cycle of healing that is significantly upregulated. And none of this is a miracle. All of this is one brick at a time, common sense, you build the solution. So again, when people go, oh, that doesn't work, I'm always interested to, I'm kind of like, first of all, then what does? But also, do they have any understanding of the complexity at which a true functional medicine, integrative medicine approach would come with? So autoimmunity, I'm not going to spend a lot of time on this. This basically is, our answer to a lot of the idiopathic or incurable diseases. It just is amazing to me that in medicine, we've labeled like half the neuroendocrine disruptions that happen as incurable. Yeah, there's a genetic component to this, but the triggers, the amount of these diseases is significantly up in the last generation. Well, what happened in the last generation? So in 50 years, we kind of wrecked the environment. So in 50 years, we GMO'd the grains, and then we changed what cows are. So milk and wheat are now very, very different molecules. So now the ADD, ADHD, especially in males, is off the chart. And in general, we have a whole group of internal medicine people, of the endocrinologists, who are saying none of it has a reason. So there's no triggers that we can identify. When we're looking at a triggers list and we're going down, and again, this is kind of our cheat sheet, but food, antigens, metals, stress, hormones, pregnancy, pesticides, poison, and trauma, this is half our patients. So it's not just a few people. And it's always news. It's always like, well, that's just how I am. Well, it is how you are, but it got done to you. So we're looking at what's the underlying cause, what is there to be done about it. This was my book I wrote. I was really sick, so I was like trying to just get it down on paper. I'm going to rewrite it. So, add in the regenerative medicine stuff and add basically the things that we think are kind of the handbook on how to do integrative medicine. This is kind of a repeat of that point, but the exposures in daily living are things that, we don't want to re-expose ourselves to. So there are people that are eating the same food, the genetically modified food, or foods that are changing their blood glucose, the hemoglobin A1C levels to a point that's just catastrophic. And so we're doing a lot of neuropathy because we have new technology that addresses it. But you see these people and go, yeah, my doctor said I could eat anything as long as I took my insulin. And I was like, Google how long people on insulin live, because it's really not a great answer. And then remember, nobody thinks you're going to change your own A1C levels. There's a lot of discussion about it, but no doctor is going to spend any time with you to actually enable you to do that the way the current medical system is set up. It's crucial. You've got to fix blood glucose. You've got to fix, intercellular reserves and energy. You can't poison yourself. You've got metal toxicity or hormone disruption or pesticides. Those are permanent. You have to route them out, figure out how to detoxify it or chelate it, and then go forward. And so one of my things about Americans is basically if we can't see it, it's not there. And there's all kinds of prothetic statements that says that which you do not see can not only make you sick, it can kill you. So we're looking at these exposure to daily living now with the electrosmog, with the, all the different things. We're looking at a real toxic load. If we can get rid of that with most patients, we change their life. So what are clinical results of a combined approach? And again, one of the things we're trying to do is objectify things. It would be very nice to go in and see at a microscopic level that tissues actually changed. We don't have that capability, but what we do have the capability is to measure strength and range of motion. And these are objective things. These are considered signs in medicine. So our average clinical experience is a 55% increase in these measures. And you can see in this particular patient, their shoulder movement was up about 50%. The neck movement was 30% on one side and 60% on another side that was stuck. Their grip strength, and let's just look at those actual numbers. So their grip strength started out at 45 and went to 65. Well, 40% change in upper body input to your brain. So remember the sensory homunculus is kind of a map of everything you're perceiving, and it goes to your brain and it supercharges your brain. So the more input you have from your body, and your upper body has a lot more input than your lower body, kind of the better you are cognitively. So we look at this and go, we're expecting balance and cognitive changes as a result of this. When we're looking at leg strength, so you need about 40 pounds of leg strength. This guy is 17 and 19. So he ended up at 32 and 38, not quite 40, but enough so he can get out of a chair without holding on. So this is basically a 2 cc IV push of stem cells with 3 or 4 sessions of rehab. This is not the guy spent a ton of time doing rehab. This is literally how good the stem cells work. So we're at, I think the number is like 110,000 procedures. So there's huge amounts of reference studies. So we get people going, it's unscientific. And I go, you're not very good at research then, because there's huge amounts of research. Now there's lots and lots and lots of research. I don't know if anybody's ever looked at medical research. Medical research always ends with, yeah, and we need more money for more research. But the reality is that the clinical outcomes on stem cells are spectacular. And I think that they're about twice as good as surgery. So I think that, the jury's still out on that because it's very hard to get information. And frankly, the people that are doing some of the best work aren't sharing it because it's still in that, let's prove ourselves and let's stay below the radar. At the end of the year, we're probably going to publish our results because we have 3 years at this point. And it's pretty significant, not just in the safety record, but in the efficacy. So again, we like umbilical cord stem cells because they have the highest safety record and they have the most colony forming units. So talking about COVID, COVID's a real thing. So it's a SARS level, MRSA level virus. So it means it started out as a supercharged virus. It's that crown, it makes it immune to a lot of white blood cell activity, and people that are immune compromised, and which is usually the older population, can die from it. I mean, we've all seen the examples of it. I'm not going to get into the politics of it all, but we're taking it seriously. Having said that, we bought the ability to do in-house COVID testing, so the fast testing. So we test our staff every 2 weeks, or if we think any incidents have happened. We had one staff member who actually knew a person, so we sequestered him. And, and again, he's tested 3 times, he's clear, but we're not letting him back in the clinic until the 2 weeks. We're just making sure. Because we have 4,000 square feet, we can give more than the 400 square feet to each patient. I think we have to give 250, some number like that. We're using specialized air handlers and environmental sanitation. So we're cleaning not just with bleach, but with micellized silver, and making sure that everything's sanitized. One of the statistics, a lot of functional medicine, and proof is in the pudding. So we have about 1,000 patient population, and we don't have one person that has COVID-19. Now, our patient base is, relatively sophisticated. They're older. They're sequestering. They're doing many things right. But, that's a pretty safe deal. At the point that we can open up again and do patient webinars, workshops, I'm probably going to do that because I actually think that this information is crucial and getting it out. We're going to do these webinars until then, but I think if you have the reasonable precautions, and I think the ones that have been put out by our county are actually great, then I think you're pretty safe. So looking at this, kind of applying it to yourself, what kind of patient actually uses Regen Techniques? And it's really people that don't want a surgery or are done with the drugs. We regularly get people that say, I just don't want to be on gabapentin anymore. Or I don't want to be on the 10 drugs I'm on anymore. So we always have to be careful with that because we have to work with the medical provider. We have to make sure that this is clinically indicated, and we have to make sure that, the best interest of the patient is there. But I think coming in with with a less than let's throw 10 drugs at the problem technique is responsible for a lot of what people are wanting here. So, looking at the newest rehab techniques, basically when you look at what Germany's doing, when you look at what Japan is doing, our rehab techniques just come up really short. I mean, the reason we're throwing drugs and surgery at everything is because that's all we really have. So when we're looking at the people who want this kind of care, they want the latest in the technique. And then part and parcel of it is, they kind of got the memo of you're responsible for your own health. Doctors are really consultants at best these days, and that, you have the responsibility to really figure it out. And let's face it, diagnostics are pretty wanting in most healthcare environments. So what can you actually do? I don't want to make this sound like a commercial, but I do want to make it so that you have an avenue to get your questions answered. We put a ton of stuff on advancedregen.com. That's our website. So www.advancedregen.com. Basically, that is going to give you a couple videos, which we use for our patients. So at the end of a consult, we say this person needs to look at autoimmune triggers. They need to look at 40% glycemic eating. They need to look at sensible exercise. There's 3 or 4 or 5 of those videos that are on there. The other thing that's on there is probably 50 research articles. They're the original ones we did, but it's all pretty good. At the point you're ready to go forward, this is our main telephone number, and you literally can call up and set up a 15-minute consult with me. And that's really if you have, it's kind of a pre-screen both ways. We look at it and say if there's something that you have that what we have could address, and whether, we're a fit. And then when you're really ready, you can either call that number or look on the website and set up a consultation. So that doesn't cost you anything. We're sort of leaving it open. And then we evaluate your situation. So in that, we're talking about doing we're talking about doing an evaluation that has a neuro-orthopedic evaluation, but also looks at it from a functional medicine point of view and tries to figure out the underlying triggers. So in most cases, we can either design some kind of a solution that works for you or get you to somebody that can. I'm going to look here, and we've got a series of question and answers. This is a great question. So please address chronic neurologic issues, muscle atrophy, tingling, vein swelling, and best to treat. Complicated question. So, hi, Catherine. So I think when we're looking at that, chronic neurologic issues, you know, especially when we were doing brain scans, it was very easy to quantify those things. So most of the neurologic issues that we're dealing with now are orthoneuro. So they're balance issues, they are muscle atrophy. The rest of the things are kind of peripheral neuropathy. So when we're doing that initial exam, we're going to evaluate the different levels of problems. It's called the longitudinal level of the lesion. And we're going to say, is this a spinal issue? Is this a peripheral nerve issue? Is this a metabolic issue? What's causing it? When we're looking at neuropathy, neuropathy is this little world in itself because, you know, you can injure your low back and it's an L5S1. And so we know that that's originating there. We can look at the actual transmission of the signals. So if you do a vibration test, the patient won't feel vibration. So those are Pacini corpuscle, actually transducer problems. And then we would look at blood sugar, we would look at metals, we would look at all the different things that might do that. Synexis is the treatment for peripheral neuropathy. Pulse electromagnetics is more like a generalized workhorse. And again, pulse electromagnetics can help us with mitochondrial function. So it's that, you know, there lots of people generalize health as one or two things. And one of the things that a lot of people like to fix is mitochondria. They're basically saying that, you know, it's the powerhouse of the cell, and if it works, then everything else works. We don't think it's that simple, but we certainly like to fix the mitochondria. We like that kind of thing. Let me go to another one. So how frequently should umbilical cord stem cells be repeated or administered? So I used to have a strong opinion that it was a one and done, that we would go in, do an injection in the knee, and then never have to do it again, because that's kind of what the research said. The reality was we have people that are redoing it like every year because it makes them feel so good, especially the umbilical cord IV stem cells. We're still working with some of the other ones. Jury's out on that, and it's almost like a personal thing. Let me see. Chronic muscular pain in lower lumbar, psoas, gluteals, sacroiliac areas, best approach for treatment. So one of the things about muscle pain is often reactive to either neural or skeletal issues. So in that area, you know, the pelvis has that sacrum in the middle, the iliac crests are locked onto either side, and it's got a 5-inch well-innervated joint in the middle. Well, the net of that is that if that joint becomes disrupted, and an SI lesion is a pretty standard chiropractic thing, it's serious, but it's not hard to fix for a good chiropractor, then all those muscles are going to compensate. Well, muscles are not nearly as strong as bones or ligaments. And so they then get significantly overused. They can be sprained, strained, and they can definitely have pain. So when we're looking at those kind of things, again, we always want to look at what's the underlying cause. And then, you know, the hierarchy is physical, biochemical, neuro, and energetic. So we're looking at those things and saying, okay, what could we really do? Well, the answer is you're going to try to fix the underlying joint first. There may be chemical problems. We've definitely seen calcium magnesium imbalances and things like that. But generally, we would view that as musculoskeletal, and we would look at it from a physical point of view. These are great questions. Now, this is a new anonymous attendee. I've never had a knee injury, but as I'm aging, my knees are starting to hurt by the end of the day. Would I be a good candidate for stem cells or amniotic product in my knees? Very nicely worded question. And the answer is maybe. So two things. You need some kind of an evaluation. So we can do a physical test that'll show us things, but knees are easy because the cartilage, you have the tibial plateau, and then you have the condyles from the two bones that kind of caress or house the meniscus. And you can measure on X-ray exactly what's going on. We can do an evaluation from a functional point of view to see how much flexibility there is, how much strength there is in the system. But again, we would never do stem cells or actually any procedure until we had a diagnosis. So in this case, a relatively inexpensive, easy to get X-ray or ultrasound would be indicated. My son is 21 years old and had significant injury to both of his knees. He fell straight on them. When we did the ultrasound examination, we found pockets of swelling and fluid, and the tibialis anterior, the main ligament that goes in the front of the shin was literally torn. So when we did exosomes and stem cells on that, we actually created a whole new health thing. In general, we don't think young people need stem cells because you have a lot. If there's a trauma case or an autoimmune disease, we have a couple of things on our website where we're showing huge changes in skin and autoimmune reactivity in young people. So when we're looking at it, we would, again, case by case basis, but the X-ray or the ultrasound is going to, give us an answer there. Let me see. All right, here's a political one, Erica. Proposition 14 passed on stem cell research funding in California. Will this affect the procedures, pricing, or insurance coverage? I don't think it can hurt. I was a little surprised to see it. I'm not sure that I view that as a state level thing, but I'm not against it, kind of a thing. I think some things are national because of the scope of it. I'd rather see NIH do it than California, but what the heck. So I think it's part of the acceptance of things. It's good to see California taking a leadership role in medicine because we really haven't done so great lately. I think it's just part of the forward inertia of this getting to be accepted by more and more people. I'm going to take one more question. So patient said, hi, I came in late. I need a hip replacement. Is this something that can benefit me? And the answer is it depends on what the femur head acetabulum looks like. If it's the right shape and it just doesn't have the cartilage in between, then remember how stem cells work. The very first thing they do is they decrease inflammation. Some people think that's amazing. We've had people walk out of the injection and go, they're fixed. And we go, you're not fixed, you just don't hurt anymore. So there's a big question about what is the capability of the stem cell to regenerate that labrum or that cartilage pad. And we think that there's good science that that's actually happening. It's all anecdotal at this point. We've treated several people that had hip replacements. We've treated several people that didn't get the hip replacement because they did the regenerative therapy. We like both things. I think that in general, we would view it as a viable option. It's definitely something we would need to look at the films at and see how bad it is. Quick answer, if the femur head is still round and it's not distorted, you're probably a candidate. if there's a complete distortion of that joint, remember it's that ball and socket joint, if it doesn't look round anymore and the stage of arthritis is too severe, then we have recommended hip replacements before. You know, it's one of the things that we don't think is out of the question. Somebody snuck in a last one, and I'm going to do this one just because it's such a big deal. I'm not a smoker. I've never been, don't have COPD, but I think I have weak lungs and feel short of breath a lot. This year has been bad for me lung-wise because of bad air quality. Would stem cells intravenous be good for me? Great question, because this is going around a lot. So one of the things an IV does is it goes in, again, the pathway gets you to the lungs. And one of the things that we've seen is people with very, very compromised lungs, which is getting to be a lot of people these days because of the air quality, because of the fires, where stem cells are really helping that. I think in general, you know, and again, I don't like generalized kind of answers, but we would definitely look at it. Again, we do a spirometry test. We'd look for the underlying cause beyond it, but, you know, definitely forest fire, air, just the amount of the particulate matter that's been dropping on us in the last little bit would indicate to us that you know, there's something to be gained there. So these are great questions. One of the things is if you go on advancedregen.com, and I think that there's probably a way to send us an email from there. If they're not, let me just give you our main email, which is clinicalcare@advancedregen.com. If you send any of the questions to that, I'll personally answer them. The other thing you can do, again, is call our office. Definitely look under advancedregen.com. It kills me when people kind of don't have the basic information because it's really all there. So we've spent a lot of time on this website. So you can set up a 15-minute phone call with me. And the purpose of that really is, you know, where are you now? What could be done? Is there something that we can put together that could help you on your path? I'm all about efficiency. I think it's immoral to waste time or money. So part of my stoicism says that I should make myself available. Part of my common sense says I don't want to make myself available if it's a waste of time. So do your research first, and then you can set up a 15-minute consult. If you're pretty sure that this is for you, you can just set up an in-office consult, contact the front desk, they'll send you new patient paperwork, and we'll be in a position to evaluate your situation. This has been great. I appreciate everybody staying to the end. We're probably going to have this as a replay, so it'll be on our website at a certain point. Again, thanks a lot.